Rationale for colorectal cancer screening. Familiarize yourselves with the target population, and we'll go over some of the data explaining why these are the appropriate target populations, and then summarize different recommendations. We'll walk you through a number of the screening algorithms. So why is colorectal cancer screening uniquely suited for screening purposes? There are a number of reasons for that. First of all, it's a very common cancer, as you know. It's highly lethal if it's caught late. And there's a long asymptomatic preclinical phase. This is the rationale for going ahead and performing colonoscopy, finding polyps, removing polyps. And we'll go over some of the data with regards to that. There are accurate screening tests that are widely available. In fact, there are a number of them that have been demonstrated, including in randomized trials, to decrease not only incidence but also mortality for colorectal cancer. So indeed, early detection of cancer or actual polyps that predate cancer improves survival. And finally, the benefits outweigh the harms and cost. And just so that you know, with regards to cost effectiveness, colorectal cancer screening, indeed, it's actually the most cost-effective screening program, much more so than breast or cervical cancer screening. So in lieu of introduction, if we look at the epidemiology, I'll focus more on the right-hand side. On the left-hand side, you've got the most recent statistics from Canadian cancer statistics on colorectal cancer. So it's the second most common diagnosed cancer if we remove skin cancers, and it's the second leading cause of death in men and third in women after breast and lung. It's estimated, and this is a number that I do remember when discussing with patients the importance of screening. So it's 1 in 13 Canadian men will develop colon cancer, and 1 in 29 will die from it. It's a little bit less common in women, 1 in 16, 1 in 34. So it's an extremely common condition that affects all Canadians. So let me spend a couple of minutes on age. You may or may not have heard that there have been a number of changes in the recommendations for age for screening. So throughout Canada, all provinces and territories target patients aged 50 to 74. The reason for this, as you can see, is really around age 50 where the incidence of colon cancer picks up and moves on. You may have heard in the States that based on recent data over the last 7 to 10 years, it appears that we're seeing more younger patients with colon cancer. It's unclear why that is. It's unclear whether it's due to a lead bias and better detection methods or not, but it appears that there probably is a true incidence, increased incidence in younger patients that has led the American Cancer Society to actually decrease the number at starting for screening to 45. You may have heard about it. It made a lot of noise. It has a huge impact with regards to resources and so on. We have not gone to 45 as an initial screening age in Canada, but it is now in the States, not by all societies, but some of the major societies. So you're looking at 45. If you look now, on the other hand, at the age 74, you can see that if you go beyond 74, in fact, the incidence of colon cancer continues to rise. So the question is, why do we stop screening at 74? And the reason for that is because of competing risks. So that patients start dying off of other conditions, and it's been modeled and so on, is not worth the cost or the benefits because of the associated risks to screen patients beyond age 74. However, you should know that in the States, a number of societies recommend a higher screening age. One of the societies goes up to 80, and in fact, I think the American College of Gastroenterology has no upper age limit. There's been modeling done published in the Annals of Internal Medicine, one of the major journals in the US, suggesting that in someone who's reasonably good health, you can probably go up to age 86 or so. This is not what we do in Canada. Because we have population-based programs, we do not have what's called opportunistic screening programs. And in organized programs, population-based, it's 50 to 74. That's true throughout Australasia, Europe, and is true in Canada as well. So 50 to 74 is the target range, but you may want to discuss with patients and explain to them why that is, because a number of questions come about when we're discussing this with them. So these are the guidelines from the Canadian Primary Care Colorectal Cancer Screening Guidelines for colorectal cancer, and they're actually quite controversial, and I'll go over them with you. So a couple of things that have been done differently in Canada. First is they split the recommendations between age 50 to 59 and 60 to 74. suggesting that there was a strong data, so moderate to high quality data, suggesting a strong recommendation for screening in the 60 to 74. However, less good data in the 50 to 59 range. At the end of the day, it doesn't make a difference. We still screen the whole 50 to 74 range, but just be aware that the Canadian Primary Care Task Force felt that there was less good data in the younger 50 to 59 range, and beyond 75 did not recommend further screening for the reasons I've told you about. As to the modality and the interval, so you have GAIAC right now in Ontario. As you know, you're moving to FIT. Most of the rest of Canada is already at FIT or is moving towards FIT as well. And I'll come to the data that suggests why that should be. Indeed, that's probably the right decision. And the FIT is done every 2 years. You probably know, and if you don't, there's actually 5 randomized trials that all looked at flexible sigmoidoscopy, showing that it is a tremendous screening method, resulting in decreased incidence as well as decreased mortality of colon cancer. And a meta-analysis of all those 5 has indeed shown it, either FlexSig alone or FlexSig in a conjunction with the use of FIT or GAIAC. And the recommendations there is to do it every 10 years, although some have suggested every 5 years. Now, in the States, certainly sigmoidoscopy has been compared to a one-breast mammography, where you only see part of the issue. Obviously, you're only looking at a quarter of the colon, and this has not been taken up widely in the States. In Canada, as you know, there's been a number of programs, including in Ontario, where nurses were trained to do flexible sigmoidoscopy, but it has not really caught on either, I don't think. Just as a side note, in the UK, they actually, where they generated one of these large randomized trials, have for a whole subset of population a once-in-a-lifetime FlexSig starting at age 60 for the patients who prefer that, with the rationale that any screening is better than no screening. It's not an issue of who does the sigmoidoscopy, because in the UK, nurses are trained to also do colonoscopies and actually to also do polypectomies. So that's not an issue there. But in Canada, I think for all intents and purposes, I'm not aware of anywhere in Canada where flexible sigmoidoscopy has taken off at this point in time. And finally, perhaps the most controversial and contentious recommendation of the group was this issue of colonoscopy. And if you look at it, they actually do not recommend doing a colonoscopy. So the data are that there are no randomized trials looking at colonoscopy in a screening setting of a population-based program. But rather than saying you can do it, but we don't have much data, the Canadian Primary Care Task Force group actually said you should not do it. As far as I know, it's the only body in the world that has recommended against colonoscopy. Most of the others across all continents have said the data are weaker, but you can consider it. And as you know, it is the primary method of opportunistic screening in the US right now. So just be aware of that. I don't know how you approach your patients with regards to that. We have a number of patients who come to us. I've convinced the ministry in Quebec, where I practice, that in fact we do offer colonoscopy after the patients it has been discussed with the patients, the screening methods available to them, and if they still want to have a colonoscopy, we do provide a colonoscopy. But with regards to where they stand in the pecking order waiting for a colonoscopy, it's obviously the lowest priority would be an average risk screening of primary intent. So just be aware of that. That's extremely controversial, but that's where we stand. And your family practitioners who refer patients to you, I have heard this message, and you may have to discuss it with them, decipher it a little bit, and explain the background to them. I hope that that's reasonably clear now. So now, as I mentioned, most of the provinces and territories are going towards FIT. You are migrating towards FIT very quickly in Ontario, and the preliminary data have been completed. And indeed, the reason for that is because FIT is actually a better test than GAIAC. So we'll go over some of the data for that. So first, the FIT detects more specifically human hemoglobin, and that arises from the lower GI tract. So this is important, that if you have a patient who presents with a positive GAIAC and the colonoscopy is normal, I don't know what you do, we flip them around and do a gastroscopy as well. Well, we don't do GAIAC anymore. Not so for the FIT. The FIT detects part of the hemoglobin that is degraded by proteolytic enzymes in the gut, so that if the FIT is positive, the blood is coming from the lower gut. There's a possibility that it could be the lower small bowel, but not the upper GI tract. So we do not do gastroscopies in positive FIT patients and who have had a normal colonoscopy. So that's an important issue with regards to resource utilization. Now, with regards to using the FIT, it's easier to use, it's more quantifiable than the GAIAC, and there are a number of technologies that allow us to do high throughput technology, so it's adapted to population-based screening as opposed to GAIAC. It also outperforms the GAIAC with regards to greater adoption. You can see that there's significant more greater adoption. The reason for that is you do not need to have a change in the diet. It's easier sampling, and one stool sampling is actually what's been chosen for most of the provinces. There is a 2-stool sample that can be done as well, but 1-stool sample is the one that is usually done. And I remind you, it's done on a 2-yearly basis, so that's what's been approved across Canada at this point in time. So the FIT, if you compare it to the GAIAC, provides greater sensitivity, higher rates of detection of both colorectal cancer as well as advanced adenomas compared to the GAIAC, and increased participation rates compared to GAIAC. All good things when you're running a population-based program. So this is clearly why the move to FIT has occurred. And when you're doing a screening test, the 2 test performance characteristics that are key are the sensitivity, which in this case is about 88%, but even more so the negative predictive value. This threshold depends on what is the threshold that you adopt for a positive FIT, but nonetheless, this tells you that if your test is negative, you have a low chance of having a colon cancer. And then the only other issue perhaps I would tell you is that you will see, as you move towards FIT, that if you're doing a FIT positive patient, you find a lot of nasty lesions. In fact, in British Columbia and in Nova Scotia, they now have increased the time of a colonoscopy for a FIT positive patient compared to a standard colonoscopy in an endoscopy room. They've gone to 45 minutes because we find the most whopping big polyps within those patients. Not all, but nonetheless, because it does detect pretty nasty lesions as well. And the detection rate is about 4 to 6% with regards to cancer itself. And finally, it's said that the FIT is equally sensitive for proximal as well as distal advanced neoplasia, although there's some data that just came out of Italy in the past 2 months that puts this into question, but I won't discuss this more today. So how does it, what happens when you scope these patients? So you have 2 side-to-side data. These are from Bob Hilton's group in Calgary. And what you can see is the advanced, the cancer rate would be very low, about 1%, 2%. If you're doing an average risk screening colonoscopy, advanced adenomas would be about 5 to 7% or so. And then you find the low-risk adenomas and normal. With a FIT positive patient, as I mentioned to you, you're looking at 4 to 6% chance following a positive FIT test to have a cancer, and about a 30% chance to have the advanced adenomas. And these are the large, nasty polyps that take a significant amount of time to remove. And this is why a number of provinces have increased, as I mentioned to you, the colonoscopy time dedicated to a patient with a positive FIT test. So now there are randomized trial data that are ongoing. There's actually 5 randomized trials that are ongoing comparing FIT to colonoscopy. I'm showing the results of the only fully published one, the first round of the randomized trial that has been done in Spain. This was published in the New England Journal 6 years ago. And what you can see, they've actually randomized almost 30,000 patients to either FIT or to colonoscopy. And what you find is, as you look at what happens to patients as they migrate through the study, you can see that obviously not everybody wanted to have the test done. It's very modest, but I think it mirrors what has been seen in practice. And bear in mind, this is a randomized trial. And then you can see the crossovers. The crossovers are much greater, going from a patient randomized to colonoscopy who said, wait, I don't want a colonoscopy, I'd rather have a FIT test, than the reverse, a patient randomized to FIT who went on to have a colonoscopy. So much so that if you look at the end of the day, the participation rate is higher amongst FIT patients, randomized to FIT, than the ones who are randomized to colonoscopy. And this is important because at the end of the day, probably one of the take-home messages, as long as the patient is screened somehow, that's the most important thing, because you could have the perfect test if the patient doesn't want it and doesn't get it done. That doesn't get you anywhere. So that certainly is one advantage of FIT compared to colonoscopy. Bear in mind that this is first round. We don't know what's happened with repeated rounds. It has not been published today. But let me show you the results of the first round. So what you have here are the 26,000 somewhat patients randomized to colonoscopy or to FIT. And these are the findings of these patients at the end of the first round. You can see that there is no difference in the patients in whom we found cancer. They found cancer, 30 to 33, not a significant difference between the 2 groups. So bear in mind that's a one-shot colonoscopy and a FIT done initially. However, perhaps not surprisingly, you can see that there's significant difference in the advanced adenoma detection rate. You find a lot more advanced adenomas in the colonoscopy group as opposed to FIT. Why? Presumably because these don't bleed, so the FIT is negative. The question is going to be, with repeat cycles, with a FIT every 2 years compared to colonoscopy, which is 1 in 10 years, Will these patients actually be detected early on enough that these advanced adenomas could be removed? Or if they have cancer, that these cancers at early enough stages so that the mortality is similar between both groups, or even perhaps better in the fit and so on. And this is what we don't know. This is why nobody knows right now whether the best screening test modality of first intent in an average risk population is either the FIT or colonoscopy, because we just don't have these data. And unfortunately, because as you know, it takes 15 years to go from a normal mucosa to a polyp to an advanced adenoma to cancer, we will not have the results from this study for another 7 to 10 years. And true for the other 4 randomized trials going on right now. But at the end of the day, the take-home message, the number needed to screen is more modest for colonoscopy, is more so for FIT, understandably. But if you look at this, the number needed to scope, obviously, is much greater if you're randomizing your patients or if you offer them as first intent colonoscopy as opposed to FIT. So the FIT is a screening test. We may miss a few patients. We may not detect far enough. We don't know yet. We'll have to see. But what's sure is that the number of colonoscopies needed, if you use FIT as the first method of detection, clearly is much less in using colonoscopy resources than actually asking the patients to have colonoscopy of first intent. And this is why I think it's obvious to everyone that all of the provinces have gone towards FIT as a primary screening modality. It's also why the evidence is present there for FIT, is still lacking for colonoscopy, and this is also why the primary research group in Canada has recommended FIT and not colonoscopy. So now what about this? If we're going to send patients to FIT and so on, what happens with regards to colonoscopies? How are colonoscopies used? Well, if you actually look and see the way colonoscopies are used, FIT, not FIT, population-based, opportunistic-based program and so on, you can see in the States that the screening colonoscopies, in 46% of patients, they had an earlier than recommended colonoscopy. So if you're trying to actually not use too many resources, and FIT is supposed to do that. Obviously, if we're going to end up colonoscoping most patients anyways, or many patients anyways, you do not get the benefit from that. And in fact, that's true both in Canada and in the States. The predictors of overuse include a male sex, the presence of comorbidities, and colonoscopy performed by a high-volume colonoscopist. Another study, look at this, with regards to use of colonoscopies compared to what's recommended, 88% overuse as a follow-up for screening and 49% as a follow-up for surveillance colonoscopies, meaning bringing patients too early back, too frequently, following, for example, the detection of an adenoma. And in Canada, these are American data, in Canada you can see that the colonoscopy overuse is about 35%. So a huge amount of erring on the side of caution, where you bring patients back more often, more frequently, perhaps than what the recommendations are at this point in time. Predictors of overuse, if we can call it that, of colonoscopy would be general surgeon, as opposed to a gastroenterologist or to an internist, and an endoscopist practicing in a non-hospital setting. These are associated with an increased likelihood of repeating an earlier colonoscopy than what the guidelines recommend. So this is the background, if you will, to give you an idea of the use of colonoscopy based on the limited data that we have right now. And this has been found now in about 12 studies, and the overuse rate is anywhere from 30 to 50% as a rule across the world. So who in fact should have colonoscopy in the context of a screening program or a surveillance program? So clearly we're talking about patients with sporadic. So these are the average risk patients who have no personal or family history of polyps or cancer. By far and away, this is the greatest, largest group of patients who we're looking at. Family history, and I'll come back to that because there are new guidelines that actually were supposed to come out Monday, and it's been delayed, but I'll share with you the data of the new Canadian recommendations on who to screen amongst patients with a family history of colorectal cancer. Then you have IBD patients, as you know. IBD patients, usually pancolitis or extensive left colitis of anywhere from 10 to 15 years, whether it be Crohn's or ulcerative colitis, are at risk for developing cancer and should be surveilled anywhere from 1 to 2 years. Those are the current recommendations. And finally, but it's a small group, obviously, and finally, a very small group of patients who have a genetic syndrome, let it be FAP or HNPCC. I won't discuss these anymore. They're really a very small group compared to what we're discussing today. So I just want to share this with you briefly. This is how in Quebec, even though we do not have an organized program just yet, we've actually tried to streamline the process of performing colonoscopies. And this form is now used if you want a colonoscopy in Quebec. Every referring physician, let it be a specialist, a generalist, an endoscopist or not, need to fill out this form. And this form, the goal of this form is actually to try and provide, as I said, streamline the various indications of colonoscopy and provide an equitable access to colonoscopy to patients. And I just wanted to share with you the philosophy behind it. It includes administrative details. Down here is actually a list of comorbid conditions that preclude so-called open access colonoscopy. We do open access anywhere in 50 to 70% of all the patients we see. The ministry wants us to do that to try and decrease wait times for colonoscopy. So if a patient has a history of diabetes or on anticoagulants and so on, one of these boxes is filled out and the patient needs to be seen beforehand, either by a nurse or referring physician or the endoscopist and so on. And then this is the bulk of the form is this one. It includes a list of indications with recommended wait times depending on the indication. And these are all approved indications. We've tried to limit the ones that are not approved where there's little data available for a given indication. And we've tried to prioritize these. So for example, a positive fit, I'll come back to that in a short while for you, but has a higher priority rating, for example, than someone is under age 40 and has bright red blood. Because this, remember, is for all colonoscopies, not just screening, but also patients who require colonoscopies because of presenting symptoms and so on. So I'm happy to discuss this with you. I'll just throw in an example for you. One of the recommendations, indications for colonoscopy would be that of post-diverticulitis. As you probably know, there are good data to suggest that routine post-diverticulitis does not need a colonoscopy. It's if the patient is 50 to 74, you can do a fit in that context and so on. Once the patient is settled down, you're not doing it for diverticulitis, you're doing it for screening. But we recommend colonoscopy specifically if imaging has suggested that there's a possibility, something concerning either some thickening in the sigmoid or wherever the diverticulitis process is ongoing, or of course if there's a suspicious lesion present. Another example would be patients who present who have adenocarcinoma of unknown origin. There's actually a number of studies that have looked at this and found that it's actually not all cost effective to do routine colonoscopies in that group of patients, and so on. There's a number of indications that we all perform where the data have changed, and we've tried to integrate recommending not prioritizing these indications with a lower yield as part of a teaching initiative that is linked to the dissemination of this particular form. I think this type of form that is trying to, again, provide an equitable access to limited resources of colonoscopy for patients in screening and patients who have symptoms in an equitable way, in a prioritized way according to indication, is being developed in a number of provinces at this point in time, but it is in function right now in Quebec. Okay, so with this in mind, now perhaps we can get to the brunt of it, and what I wanted to do over the last 10-15 minutes or so is just go through the screening algorithms with you. So first, average risk patient. This is the basis patient and who we would do. So as we mentioned, these are patients who are average risk, meaning they have no symptoms and they have no family or personal history of polyps or cancer. Age 50 to 74, if they do not have any significant history of, as I mentioned, cancer or polyps, if they have no inflammatory bowel disease and don't have obviously a genetic syndrome, these patients should have GAIAC, but GAIAC, as you know, we're moving on. The FIT every 2 years are the recommendations at this point in time. So this would be the way to go. And I hope I've been pretty clear to you as to why we recommend FIT over GAIAC, and that's why obviously Cancer Care Ontario is moving to FIT at this time. Okay, so these are busy slides. I'll try and run through with you on them, just to go through it. So the patient who has FIT, if the FIT is negative, this patient comes back in 2 years for the follow-up FIT, and the FIT is done every 2 years. If, on the other hand, the FIT is positive, if it's an incomplete colonoscopy, the recommendations are to prep the patient better and repeat the colonoscopy. If it's an incomplete colonoscopy because of a stricture, then you can consider other methods of imaging in that particular patient. In Quebec, we recommend going through and repeating a better prep on the patient within 30 to 60 days. Don't ask me why. I have my thoughts on it, but it's not evidence-based. You find more polyps in patients who are not prepped well the first time around. I don't know if that's because we pay particular attention the second time because it's 2 exams as opposed to 1 and so on, but just be aware of it, and that's the rationale for that. In the States, they recommend doing a repeat prep and a repeat exam within the year. So now if a patient is a FIT positive and you do a complete colonoscopy, so this is controversial. So just to go with you, FIT positive colonoscopy is good quality colonoscopy, and that patient, it leaves for 10 years. and then comes back if they have no other risk factors in 10 years for a FIT every 2 years. There's limited data, but the data suggests that if a colonoscopy was a good quality colonoscopy, you're not missing anything there, and there is, we know, a false positive rate related to FIT. If it's a positive colonoscopy, then it depends on what you find. If it's an advanced polyp, advanced adenoma, I'll show you the risk stratification algorithm scheme for that. If it's non-advanced adenoma or if it's cancer, the patient is treated accordingly. So that's the algorithm, the general algorithm for a FIT-based, population-based program, which is what you are having in Cancer Care Ontario, moving from GAIAC to FIT. Now, if we move on, family history is a huge issue. On Monday, the Canadian Association of Gastroenterology and the American Gastroenterology Association linked together to define new guidelines for family history of colon cancer. It's really a mixed bag. It's really tough to follow, and the recommendations are based on the following at this point in time. So first of all, the definition of family history is one first-degree relative with colon cancer diagnosed under the age of 60 or two first-degree relatives diagnosed at any age. That is what's considered the family history. Standard screening and surveillance for these patients with a so-called positive family history is to start screening anywhere from 40 to 50 or 10 years before the affected family member, and after that to do colonoscopies every 5 years. So you may ask me, what about patients who have a second-degree relative or two second-degree relatives, even maybe if one was younger and so on. So this have fallen off the map at this point in time based on the available evidence at this point in time. There are differences that exist right now. So these guidelines are just coming to play. In fact, they just have been published, and they were supposed to be released to the press on Monday, but there's been a delay in that. So there are some differences from province to province. In Ontario, there is no age cutoff for first screen. You can start screening at age 50 rather than age 40. And the surveillance is every 5 years for the so-called family member of a positive family history at age less than 60, and 10 years for those over age 60. So the frequency of interval screening depends on how young or how old the patient was. If you're completely lost, welcome to the club. The key messages there are the following. The younger the patient was, the relative of the patient with affected colon cancer, the higher the number of relatives with colon cancer, the higher the risk. So you start earlier and you go ahead and do colonoscopy more frequently. And the less the number of patients or the older the patient that was affected, you start at age 50 rather than 10 years before at age 40. And you can even, in a subgroup of patients, follow a FIT rather than colonoscopy. So those are the general principles of the new screening guidelines for so-called family history. It becomes even more confusing when you look at polyps. The problem with polyps, as you know, we're all practicing clinicians, is that you'll tell patients, do you have a family history of polyps? Yes, Auntie Wendy had a polyp, Well, first of all, it could have been a uterine polyp for all we know. I mean, unfortunately, a number of patients I find don't understand completely. And then, of course, the data on polyps is supposed to be for advanced adenomas, not for low-risk tubular adenomas and so on. And most patients don't know what a histology is, understandably. So this is really a mixed bag at this point in time. And of course, a third of patients over age 50 have polyps. Not all those develop cancer, the low-risk ones and so on. So it's very difficult to define guidelines for so-called family history of polyps. It's a spectrum. As you know, the low-risk adenomas have very low risk, and in fact, and the advanced adenomas have a much higher risk. So the guidelines vary. There's no description of what a polyp is, let alone an advanced adenoma. The new CAG guidelines, Canadian Association of Gastroenterology guidelines, is that the family history of advanced adenoma, if you know that there was an advanced adenoma or greater, is to start screening age 40 or 50 or 10 years before the first degree relative, and then to proceed with either FIT or colonoscopy, again, based on the age of the patient and based on the degree of relativity to the patient who you're seeing in your office right now. So family history of polyps is a mixed bag. I think it'll continue to be a mixed bag. I think we're going to continue referring patients probably too much amongst these groups. I think the answer to that will be when you have organized programs and patients are followed and you have better electronic information, be able to actually make more heads or tails about whether it was an advanced adenoma or what have you. But right now, it is an issue. It's nobody's fault. Patients aren't trained histologists, so very reasonable to understand the situation right now. So now if we come back perhaps to some of the remaining algorithms. So if a patient has a personal history of colon cancer, so I remind you that the patients who have non-obstructive disease, it's 1 year, 3 years, and 5 years following the initial, the operation for cancer that the patient is screened. So 1, 3, and 5. If your patient had actually a colonoscopy, but it was obstructive because of the cancer, that patient should have a screening, clearing colonoscopy within 3 to 6 months after the cancer surgery to make sure that there's no metachronous lesion, synchronous lesion, or early metachronous lesion present. And then they can go through the 3 and 5 year program thereafter. And then there's a couple of, I won't go into details, but obviously patients who have family syndromes, it's a different issue. And patients who had rectal cancer is a different issue as well, where the patients are actually screened more frequently, anywhere from 3 to 6 months for the first 2 to 3 years, and then they go through the 3 and 5 year program in follow-up. So that gives you an idea roughly about the algorithm for patients with a diagnosed and operated colorectal cancer in time. Now, personal history, either the patients have small polyps and non-advanced adenomas. We now call it non-advanced polyps because you also have sessile-serrated polyps. So I'll walk you through these. Small polyps, small hyperplastic polyps, forget it. There is no increased risk. If a patient has a polyp under 10 millimeters in the rectum or the sigmoid, these patients go every 10 years to a FIT. This does not in any way increase the risk of the patient. And I remind you that if you see a hyperplastic appearing polyp under 5 millimeters in the rectum or the sigmoid, you leave it in. You should not be taking it out. It just increases cost for the whole healthcare system needlessly. So if it is a hyperplastic polyp, rectal sigmoid, 5 millimeters or less, you leave it in. 10 millimeters, between 5 and 10 millimeters, obviously you take it out. But if it's under 10 millimeters, rectal sigmoid, it does not increase risk. This patient can be followed up with FIT every 2 years from 10 years following the colonoscopy. Now, if a patient has a so-called non-advanced polyp, we're looking at 1 to 2 small tubular adenomas under 10 millimeters. This patient can go to, with the current recommendations, colonoscopy every 5 to 10 years. And if when you scope them again, you don't find anything, then they certainly can go to every 10 years at that point in time. Sessile-serrated polyp under 10 millimeters without dysplasia, they can go to every 5 years. So the sessile-serrated polyps, I presume you're familiar with that entity. It's a different genetic set of mutations that occur. These are usually very flat. These are usually found on the right colon, and the evolution from nothing to a polyp to cancer appears to be more rapid than the tubular adenoma, the so-called adenoma cancer sequence. And so this is why the sessile-serrated polyps, we proceed every 5 years, not every 10 years for those patients, just so that we're all clear. And those are the ones, unfortunately, that are often hard to see on the right side, often covered by a layer of mucus. For reasons we don't understand, the mucus sticks on these polyps, and these are the ones that can be missed as well. So you need to be very careful about the sessile-serrated polyps. They represent about 30%, we think, 30% of all cancers come from sessile-serrated polyps, and 70% of all cancers diagnosed come from tubular adenomas that degrade downward. Okay, so I apologize, it gets a little bit more confusing here, but I presume you know this. These are recommendations that have been present for almost 8 years. So those are so-called advanced polyps or advanced adenomas. So who are the patients who you have to bring back earlier than the 5 to 10 year plan? So any patient who has an adenoma with high-grade dysplasia, if you find 3 to 10 adenomas, if one of the adenomas is over 10 millimeters, if there's villus histology within the adenoma, if there's a sessile-serrated polyp over 10 millimeters or one with dysplasia, or if a patient has more than 3 sessile-serrated polyps. So basically, anybody has 3 or more polyps and they're over 10 millimeters, they come back at 3 years. They don't come back at 5 years. And afterwards, when they come back, if they're better, then they can go to the 5 year plan. So that's the mechanism there. Then you have some rare situations here, which I'll just walk through with you. So I remind you that if a patient has 10 adenomas that are found, either at one colonoscopy or lifelong, total of 10 adenomas, this patient needs to go to genetic counseling and genetic screening. In addition, a patient who has those number of polyps obviously has to come back earlier, anywhere from usually within 1 year, to make sure you've cleaned all the polyps out. Then they can go to the 3 year plan, and based on what you find subsequently, they can go to 3 or to 5 years. If they have genetic testing and they're positive, it's a totally different issue. I remind you, Lynch is usually every 2 years. FAP FAP should have their colons out, but there are a number of additional screening that needs to be done in those patients. I think we don't need to discuss it today unless you have specific questions. And sessile polyps, if you have, this is the large polyps that you do large EMR on, you can bring them back for as long as you're concerned about whether there's remaining histology present or not. For those large EMRs, usually we're talking about wide field EMR over 2 centimeters, the recommendation is to bring them back in 6 months and to have a look and make sure that there's no residual adenomatous tissue that is present. I remind you as well that there's now good data to suggest that what you should do with those polyps after you removed the 2 centimeter or more polyp is to use a soft coag tip on your snare and just burn the edges of that, because a lot of the recurrent tissue comes along these edges. And just routinely at the initial, when you remove the polyp, or if you're doing multiple sessions, at the final session you remove the polyp, just make sure you soft coag tip the rim, the circumference of the periphery of that adenoma that you have removed, and that significantly decreases the recurrence rate. And finally, sessile serrated polyposis. So the serrated polyposis, there's a list of criteria for patients, very high risk for having cancer. This is a separate issue altogether. Again, I'm not discussing the syndromes today, but be aware that that exists. It's based on a number of polyps of the serrated polyp form and their location. Okay, so this is the new guideline that you will be hearing about coming from Cancer Care Ontario. There is no other guideline like it right now. I think it goes a huge way at decreasing needless colonoscopies, probably, and I'll try and explain it to you. So right now, the low-risk adenomas. So this would be 1 or 2 adenomas under 10 millimeters in a patient, and we keep bringing these patients back every 5 years. The current guidelines is to bring them back up to every 10 years if it looks good. The recommendation by Cancer Care Ontario is that this patient can actually come back with FIT. So they can wait 5 years and then they can go on to a FIT, as opposed to repeat colonoscopy. So let me explain to you why. There are now a number of studies, including original data out of Ontario, that suggest, and you're going to have to follow me here, that the likelihood of finding an advanced adenoma or a cancer is actually lower in a patient in whom you found 1 or 2 small adenomas than it is in someone who's never had a colonoscopy before. So this means that the patients in whom you find 1 or 2 adenomas under 10 millimeters are probably at much lower risk, and the colonoscopy is better used screening someone who's never been screened before. And it's because of this that this recommendation has occurred. It's quite a bold one, but I think that most of the provinces and most of the countries in the world who are running organized programs will go that route. This is a low-risk group of patients who actually do fine, and this is why wait 5 years and then proceed to FIT. I thank Catherine Dubé from Cancer Care Ontario for lending me this slide. The data have not come out at this point, the recommendations, but they will. So before I finish, I'd be remiss in not telling you that quality is absolutely key. So all I've mentioned to you is assuming that there's been a quality colonoscopy. And some of the key quality indicators that you may or may not be auditing yourself, and obviously Cancer Care Ontario will provide you the basis for doing that more effectively, but nonetheless, if you can, you should be doing it as best you can, are the following. Frequency with which a colonoscopy is performed at a recommended interval should be over 90% of your patients. Frequency with which the quality of the bowel prep is adequate to allow the use of the recommended screening interval should be over 85%, and we're really talking split preparations in this context. I'm happy to answer questions. If you have it, that has changed my practice. I presume it's changed yours as well. Finally, we have clean preps with this split approach. Cecal intubation rate, I remind you, should be 95% of screening patients. You should get into cecum, 90% of all colonoscopies, and cecal intubation rate includes photography of at least 2 landmarks. So either ileocecal valve, the appendiceal orifice, or if you want, although I don't like it because sometimes you can I get confused, the confluence of the tinea. You know, what they call the crowfoot, I think it's called. It's not great. I think appendiceal orifice and the ileocecal valve are much better, and you need 2 of the 3 to be documented on photography. Additional quality indicators, frequency with which adenomas are detected. This is in asymptomatic average risk individuals. These are American quality indicator guidelines that have been put forward. So in men, this is someone off the street, average risk screening, no family or personal history of polyps. You should find adenomas in about 30% of them. and in women, 20%. So the adenoma detection rate is really hard to know because you got to link your endoscopy database with your pathology database, and that represents, there are very few places, certainly in Canada, that have both databases that talk to each other. So that's hard to do. I can tell you, we just did it at our institution 2 years ago. It's an eye-opener. It really is. You always think you're better than what you are. I would mention to you as well that it obviously depends on the patients. If you're doing a lot of fit positive patients, your adenoma detection rate should be 70% or 80% if you're very good. If not, however, again, we're talking average risk patients who haven't had colonoscopies before, 20 to 30%. I also remind you that if you're going to have a colonoscopy yourself, what you want to ask the endoscopist is what is their adenoma detection rate. For every 1% increase in adenoma detection rate by the quality of a colonoscopist, you decrease the likelihood of finding a missed cancer down the road by 3%. It's absolutely huge. There are 2 studies that have shown this, observational studies. So really, the passport of quality for an endoscopist, until proven otherwise, is the adenoma detection rate. And finally, we don't have adenoma detection rate, so one of the proxies that we use for quality is documenting the withdrawal time. And I remind you that it should be at least 6 minutes for patients in whom you do nothing. From those patients where you take biopsies or where you take polyps, these don't count. But in a patient in whom you find nothing, you should be on average spending 6 minutes going from the cecum out to the anus. Okay, just that we're all clear on that, and that should be in 98% of cases. So, and please don't do what I've seen done in a number of places. It appears as a default on the EMR, on the endoscopic report. I took at least 6 minutes to come out of the patient. That's not what people are looking for. You actually have to measure it and document the actual number of minutes that you've spent, and that has been shown as a proxy to be a very good predictor of quality and of missed cancers as well. So if you're not looking at your adenoma detection rate because you just can't, at least follow your withdrawal time, because it is. And the implications for this are obviously the time that you spend relates to the quality of the endoscopy, and also probably the mindset in which you are when you're doing your endoscopy. All right, and it's been shown across many studies. Now, I did mention to you that the prep is important. Ferring is sponsoring this talk, and they asked me, I have no experience with this app, but I do want to mention to you that the time that you spend explaining to patients that it's important that they clean themselves properly is huge and correlates with the cleanliness of the prep. So Ferring is soon launching this app, PicoSalix app, reminding the patient when to start taking the preparation and the number of glasses and fluids that they've taken, and I laud them for it, because it's now been shown that whether you teach the patient when you talk to them, whether you provide written information, whether you provide them access to a website, whether you provide them an app, because there are a number of apps that are out there that have been looked at, particularly in the States, all of these have been shown to result in an increased bowel cleanliness. So it's very important, and Ferring wanted me to mention to you, it's not out yet, but it will soon be out, and the basics of it is entrenched in evidence-based medicine. So in conclusion, colorectal cancer screening saves lives and decreases colorectal cancer incidence. In Canada, provincial population-based programs are based on stool testing, principally the FIT. This is where we are, this is where we're going, and Ontario will soon be there as well. Limited colonoscopy resources require a disciplined approach to optimize access in an equitable way. Whatever way you go, think about it. You can think of that picture I showed you, what we do in Quebec, but think of the high overutilization of colonoscopies that have been noted throughout, with people coming too early and too frequently. Colonoscopy screening intervals are based on the presence or absence of a personal or family history of colorectal cancer and colorectal polyps. Think about the new guidelines that are coming out on family history, as I told you, at least the basic principles: the age of the relative with cancer, the number of relatives, and the directness of the relative. And finally, every clinician should strive to be familiar with and respect the recommended indications about who, how, and when to carry out colorectal cancer screening. So the key messages are: colorectal cancer screening is important and indeed effective. Patients between 50 to 74 with family history should be screened. FIT is the primary modality for average risk screening. A quality colonoscopy is absolutely primordial to make all this work, and surveillance intervals will be dependent on indications and findings of colonoscopy, as I hope I showed you as we went through the different algorithms. I thank you very much for your attention.